We're going to go through a little bit about care of the patient with scleroderma. Realize that there's not a lot of like standard recommendations for like what happens during an office visit, what happens during an exam. And then we're going to focus a little bit on the clinical examination. And this is really geared for the fact that I think even among rheumatology offices, there's a lot of times folks don't see a lot of people with scleroderma. So here at the university, we have a dedicated clinic, so we see more potentially than some other rheumatologists. But I think for a lot of rheumatologists, this is probably one of the least common things that we take care of. So hopefully it'll be helpful for those of us in rheumatology. And then for anybody that is not in rheumatology but maybe in primary care, it'll hopefully help you to identify when you should send someone to a rheumatologist. We're going to talk a little bit with folks with scleroderma themselves so that they can kind of tell us a little bit of the patient perspective, and then we'll do a wrap-up. So scleroderma, as a lot of us in this room know, it's a multi-organ disease. So it, like a lot of the things that we take care of in rheumatology, it affects not just the skin, although that is where the name comes from, but it can affect internal organs from pulmonary to cardiac and into GI. Today, it would be way too big of a talk to go through every single organ system that can be affected by scleroderma. So I've chosen a couple because Raynaud's and skin involvement are very common. We'll talk a little bit about them. We'll talk a little bit about pulmonary screening because things like interstitial lung disease and pulmonary hypertension are big things for us to identify early because the course of treatment of those things is a lot better if we are early identifiers. So we'll start off with Raynaud's phenomenon. So there was a nice article probably about 2 years ago, and it was from a PhD doc in Fred Wigley's lab out at Johns Hopkins. It was really interesting. They basically just described the physiology of Raynaud's phenomenon and normal thermal regulation. And what they showed is that up here on the right-hand corner are all these capillary loops. So you have capillary loops that allow for heat venting. And they're actually all arranged. You can see up here, I think I have my next thing I have like a little arrows to show us. They're all arranged in kind of vertical bundles. And then all those vertical lines are basically aligned with the skin ridges that you see on your finger. And so it's a very organized system, and it's a way for us when we get too hot, when you're running up 10 flights of stairs and you forgot your thumb drive, that you can kind of release heat and thermoregulate. It's disordered in folks that have Raynaud's, primary Raynaud's, and it's disordered in folks that have systemic sclerosis as well. So, I'm not going to go into all the details because I don't think it's hugely important for the purposes of this talk, but realize that in folks with primary Raynaud's, so this is a schematic of what is going on in somebody with primary Raynaud's, not with systemic sclerosis, you have an upregulation of the adrenoreceptors, which essentially means that if you are exposed to cold, exposed to stress, you have a pronounced response to constrict those blood vessels that go to the fingers. That can lead to some of the classic color changes that we see in terms of white being from pallor, blue, cyanosis, and then red when you get reconstituted blood flow. What's important is that in primary Raynaud's, this nutritional artery, that's the way some people will describe it, so because it's nutritional, because it's supplying the end of the digit with its blood flow. This blood vessel doesn't actually have any adrenoreceptors on it. So in primary Raynaud's, the kind of tip that we give to trainees is that you should not see ischemic ulcers in somebody that has primary Raynaud's. If you are seeing somebody in clinic and they say, I have Raynaud's, but no one thinks anything else is going on, and they have sores in their fingertips, something else is going on. Does it have to be systemic sclerosis? No. They could have other types of drug-induced vasospasm that can be so tight that it shuts off blood flow. There could be vascular flow problems more proximally. But a primary Raynaud's patient should not get an ischemic ulcer. And that's a tip because it pains me to say that we've seen people in clinic that have lost fingers and that no one has really followed them because they said, oh, this is just primary Raynaud's. We didn't think to send to a rheumatologist. So what about non-pharmacologic therapy? So what can we do? All these things would apply for anybody with primary Raynaud's as well, but it's something that we describe to folks that have systemic sclerosis because not everybody needs treatment. I would estimate that probably in my clinic, maybe only 50% of folks with systemic sclerosis are on a vasodilator like amlodipine, and a lot of folks, almost everyone has Raynaud's, but a lot of them are managing it without medications. So some of the things that will seem obvious, so it's cold avoidance. We want warm clothing for your entire body, not just for the hands, because you need to keep your core warm as well. Stress avoidance is great as well. And then I have a couple things down here just to keep in mind. So I usually tell folks that I'm seeing in clinic that it's a good idea to keep those hand warmers that you use if you're going skiing or something, to keep it in the glove box in case they had car problems or they were stuck or stranded somewhere. You can actually get battery-powered ones. Patients are always the best innovators, so I have at least 2 or 3 patients whose husbands are hunters, and so I guess Cabela sells these gloves that have basically electronic or electrodes throughout it that you can actually heat in the hands. And so people are pretty creative in ways that they can keep their hands warm. Some of these are listed when you read a review, but to be honest, I don't know that hand swinging and getting blood flow to the hand is something that I really advocated for a lot of patients. Biofeedback has really only been studied in primary disease, so we don't think it's very effective. And it might be because, again, if I go back to that prior slide, the problem in systemic sclerosis is that it's not all vasospasm, that nutritional artery usually is affected by thickening. And so some things like biofeedback, you might be able to control some of the response that you have in terms of norepinephrine release. But if you have an artery supplying it that's diseased, it's not going to have a big impact in terms of response. We always want people to not be smoking because you don't need a second reason for your blood vessels not to be healthy. And then this is listed in our non-pharmacologic, but it's obviously invasive. But a digital sympathectomy is something that we've done in a handful of patients that have been resistant to usual medical therapy. So we don't reach for that. Just to be clear, I don't reach for surgery before we would try medications, but it's something that could be considered. Again, for the purposes of this talk, I just listed the many things that could be tried, but I'm not going to go through them. If you ask me which ones have the best data, calcium channel blockers have randomized controlled trial data. There's others with technical randomized controlled trial data. One of them even is an SSRI, so fluoxetine has some of that. But again, the studies are very, very small. We're talking, I think, maybe 20 or 30 patients total. And so we usually break it up into there's vasodilating or blood pressure lowering agents that can be used, and there's antiplatelet agents that could be used. And to be honest, a lot of patients that are on therapy will be on a combination of one or the other. So a lot of folks that I see, as long as they don't have a history of stomach bleeds or other gastric irritation, then aspirin is, a lot of patients are on a baby aspirin in our clinic, and at least that's been our practice. And then again, after calcium channel blockers, there's a list of other medications. And I would say that the evidence for effectiveness sort of goes down after that. These medications down here are medications that are commonly used for pulmonary hypertension. And there is some data, but the primary endpoints in the studies that looked at sildenafil and that looked at bosentan, which is one type of endothelin antagonist, they didn't reach their primary endpoint. So there is no FDA-approved medications for Raynaud's and Scleroderma, unfortunately. So these are agents that we can try to get off-label usage. And I think that in terms of Raynaud's symptomatology, a meta-analysis showed that there is an effectiveness in line with calcium channel blockers. So when they added up all the studies together, they saw some effect. And then endothelin antagonists have showed some data for a reduction in ulcer formation. And as we're going through, if you guys have questions, please stop me. So this is just a schematic, to remind us that the vessels that get affected in Raynaud's and that get affected in secondary Raynaud's with systemic sclerosis are the distal vessels. So there may be some involvement of the deep and the proximal palmar arch, but it's usually distal to that portion. So patients with systemic sclerosis usually don't have problems with the large proximal vessels. That being said, there can be rare cases where we might actually do an angiogram to identify if there's more proximal disease contributing, but this is usually a problem with the distal arteries. And so this is shown kind of in this angiogram here, is that your proximal vessels actually look like they're filling quite well, but it's the distal vasculature. And the problem with this is that what we can do sometimes in angio is that we can then supply a vasodilating agent. And I would say that in the handful of folks that we've done this with, there's some people who don't respond to that vasodilator therapy. And again, I think in that situation, that's someone who has a lot of vessel narrowing without additional vasospasm on top. And so we will still try medications to get every kind of little ounce of vasodilation out that we can. But in that individual, it's very tough because the vessel's already narrowed to a significant degree. So what about skin fibrosis? So it's important to know that not all skin thickening is sclerosis, and there's some really good articles out there about scleroderma mimickers and other thickening conditions, because it's important to actually make sure you're treating the right disease. And so Laura Hummers from Johns Hopkins, again, has a nice article on mimickers that I think is worth reading. In scleroderma, in contrast to some of these mimickers, the involvement almost always starts on the fingers and moves more proximally. The lips can become involved, and that one of the most devastating complications is because of the skin involvement, when it crosses a joint, folks can get flexion contractures, and that's a big deal, because even after the skin thickening improves, some people are left with flexion contractures that don't improve along with their skin, and that's really a difficult situation, because once you have tendon contracture, we don't have current medications that can make that better, unfortunately. So initially, there can be some inflammatory changes in the skin. So initially, you can get kind of a shiny, taut appearance. So that shininess is a combination of the fact that there can be dermal edema or inflammation. And then you also a lot of times can get the hair follicles can become involved. And so you can see a loss of hair in that area. The last thing is that you can get a destruction of sweat glands in the area, and so that dryness really can contribute to the intense itching that is typical early on with systemic sclerosis. That can be, to be honest, symptomatically, when I see patients who are newly diagnosed, it's one of the biggest complaints, and it's a very difficult to control aspect of the systemic sclerosis. So the involvement that, like we said before, can involve the face. This is one of the terms that can be used. So because the people can get narrowing of the nasal bridge and around the mouth, then there's a German term for this, mouse cough, can develop. And I think when we go through physical exam, we'll kind of talk about the fact that the oral aperture can be involved, and that's important, especially if someone's sick enough to be in the hospital, because if someone had to have a breathing tube put in, it can be more difficult in somebody that has tightness around the mouth. So this is a patient of mine who said he didn't mind being up on screen today. So he has a classic finding that can happen, especially in darkly pigmented individuals. They can get the salt and pepper appearance of the skin, and that's because you'll keep the pigment around the hair follicle, but you'll lose some of the pigment outside of that. I think I have a closer up image, and I don't know how well it's going to project. This can be confused with vitiligo, but it's usually very different. Vitiligo doesn't usually have the sparing around the hair follicle, so that's usually more of a blanching of one single area, whereas this has a kind of a dot appearance, or the pepper in the middle. And so this is fairly specific in the right setting for systemic sclerosis. So why do we care about, in addition to skin involvement being a problem in terms of mobility and pain, why are we so diligent about a lot of times tracking the scores or the skin scores? And that's because it's in almost every study of interstitial lung disease or other GI manifestations, internal organ involvement correlates with the extent of skin involvement. So we're going to go through later on when we talk with folks who have systemic sclerosis, we'll go through the modified Rodnan skin score. But as that number goes up, risk of internal organ involvement goes up. And so that's why we think it's important for us to kind of track over time. So with diffuse systemic sclerosis, and so I should take a step back, diffuse we define as disease that's proximal to the elbow, proximal to the knees, or has chest involvement. So if you have any of those three, you don't have to have all of those three, but if you have any of those three, that technically is somebody who falls into a diffuse systemic sclerosis subset. Anything else would be a limited systemic sclerosis. And again, we like to define in that way because it helps give us prognostic information about what type of internal organ involvement they might have. Limited is typically associated with pulmonary hypertension, whereas diffuse involvement has a higher risk of rapid progression, interstitial lung disease, and renal involvement. So in diffuse, the systemic sclerosis, the skin involvement can be rapid. And so this is a patient that we are obviously worried about when they come in. So if someone already has diffuse involvement, they have relatively new onset of symptoms, this is someone we're going to follow very, very closely. We will follow everyone closely, but this is someone we're going to be more nervous about rapid progression, and we'll talk about that when we talk about the evaluation of patients. The course of the skin disease can be variable, and that makes it tough, right? So we know the traditional teaching is that at 1.5 to 2 years after the onset, that skin involvement sometimes peaks. That number really varies in the literature, but I think it's pretty consistent that the first 4 to 5 years are when someone will reach their maximum skin tightness. The problem is that some patients can have a course that they'll have some regression after that 4 to 5 year point, and then have skin that's involved later on down the line. And that makes it very difficult for studies, because you can imagine if you were going to study this and you enrolled folks that had 5, 6, 7 years of disease, if the disease is already kind of tapering off, then that's not a good time to study if a drug's going to be effective, because you won't expect to see any progression anyway. So this makes it difficult, because when we enroll folks in trials, it's usually only early on. So I'm going to throw everything I have up here just for time's sake, but these are the 4 medications that probably have the best data that are commonly used in clinic in terms of skin fibrosis. Prednisone is controversial, right? So I think we probably all know that if we use too much prednisone, it puts us at risk for what kind of complications? Yes. So there's a risk of renal crisis, and most of the retrospective data says that that's usually when you get above 15 milligrams. But I think early on, there's a lot of us, when someone has a lot of intense itching or skin inflammation and a lot of that tightness, we'll still consider low-dose prednisone. What's low-dose prednisone? Usually in the 5 to 10 milligram range. And again, we would only keep a patient on it if they said they got a lot of relief, and we usually only use it as a bridge while we're getting a different medication started. Methotrexate and mycophenolate have some data as well. Methotrexate's data is conflicting. There's some randomized trials that show no substantial benefit, and there's some that show a mild benefit. Overall, they've done a meta-analysis of the small studies, and there's a slight benefit with methotrexate. Mycophenolate, it used to be that we just had observational data, but Scleroderma lung study 2 has finally closed, and there is a decrease in the modified Rodnan skin score. Now, they didn't compare that to placebo. The comparison arm was against cyclophosphamide, so we still don't have a randomized controlled trial against placebo saying it's effective, but it does show a decline early on in disease when you would have expected somebody to be increasing in terms of their skin score. So mycophenolate or Cellcept is something that we'll use. Cyclophosphamide has data in randomized controlled trials too, but it's really used as a last resort because of how toxic it is. But I have patients in my clinic that I've certainly used it if other medications have failed, and we've had some people who've at least anecdotally had success with that medication. So I thought this was interesting. So this was a patient that I took care of who unfortunately had disease for probably about 12 to 13 years. And this is a difficult situation of what to do in clinic. So I just got done telling you that the disease can usually peak at 4 to 5 years, and then usually it stays stable. But functionally, she was obviously very, very impaired. And the question always becomes, how long do you keep someone on medication? How long if you're not seeing effectiveness? And at some point, are we doing more harm than good? And so I think we always will try medications, and I think for some patients they've been very, very beneficial. But I do want to emphasize that if we're not seeing benefit, that these medications aren't benign. And so people can get infections, and people can die from infections. And so Fred Wigley, who's really kind of a big name in the field of systemic sclerosis, just said that at times it's obviously not appropriate to treat somebody who's out of that inflammatory phase, who's in more of an advanced fibrotic stage, and that we need to weigh the benefits and the potential harms of medications. So I'm going to briefly go through some of the last couple here. This is just a slide showing that Raynaud's involvement in terms of the different organs that can be involved. Raynaud's is kind of across the board. Almost everybody with systemic sclerosis will have involvement. The GI tract is up at 75% in terms of folks who have that manifestation. And then when you go down lower, you'll see that the pulmonary involvement hovers around 50 or 60% as well. Other organs like the kidneys can be involved. So scleroderma renal crisis is obviously something that we're concerned about and want to watch. One of the more common causes of death in addition to pulmonary disease is actually acute cardiac arrest, and people can get cardiac conduction defects. And so that's not something that we're always thinking about. It's a low percentage of individuals who have involvement, but it's a serious manifestation nonetheless. And I'll go through the potential value of EKG later on. So again, there's a lot of information up here, but just know that really every part of the GI tract, from the esophagus down to the rectum, have been involved. And it takes a lot of help, I think, to be able to manage some of these symptoms. So we have an expert here at the university that we can go to, and Dr. Menard Ketcher, but there's obviously other docs in the community who sometimes we can lean upon to give us help. But these manifestations, unlike the skin fibrosis where we talked about immunosuppressive medications, outside of skin involvement or interstitial lung disease, there's not really a lot of data that would suggest that immune suppression works for gastrointestinal involvement. And so these symptoms are addressed kind of individually, one by one, in terms of whether it's an acid problem or if it's a motility problem. And so again, I think at the end, when we allow for questions, we can go through a little bit of that as well. So I'm going to touch on this briefly. So what about antibodies? So I think sometimes, I'm going to put one more up here. Sometimes the question comes up about whether every patient with scleroderma needs to be tested for antibodies. I mean, we're an academic center, so I think we have an interest in trying to categorize patients and learn more about the utility of antibody testing. But the reality is that we'll follow everybody very closely, and the clinical manifestations probably give you as much of a hint in terms of their risk for internal organ involvement. But just know that there are the two most common antibodies that represent probably about 50% or about 40% of all patients with systemic sclerosis will have either an anti-centromere antibody or an anti-topoisomerase, which is also called an SCL70. So that's about 40% of patients. There's probably about another 30% or so that have other antibodies, and you can obtain those through expanded antibody panels. But then you have about a quarter that won't have any specific antibodies. You can see here there is some association with internal organ involvement. So we said before that limited disease was associated with pulmonary hypertension. And you can see here that this anti-centromere antibody along with this THTO antibody have high rates of isolated pulmonary hypertension, whereas with an anti-SCL antibody, there's a higher rate with a low FVC that we would associate with interstitial lung disease. So again, the antibodies can give us some clue, but we're usually screening or looking for these disease manifestations. And so I would say if I was in an area that didn't have access to all the antibodies, I still feel like I can take pretty good care of folks with systemic sclerosis. The last one that usually gets a lot of attention too is the anti-polymerase III antibody. You can see here that at least in Virginia Steen's data from the University of Pittsburgh, it's the third most common autoantibody in that cohort from the Pittsburgh Scleroderma Clinic. It has an association with scleroderma renal crisis, and then it's also been implicated with the risk for cancer as well. That, I think, is still being investigated, but it might be that in the future, if we can figure out that intervention based in terms of cancer screening based on the antibody, if we find data to show that that's cost effective and actually helps improve treatment and catches people with cancer, that would be one area where I think potentially there'd be a lot of value in checking for the antibody. So again, this is, I think people who've listened to Dr. Fisher talk or anyone else has probably seen this slide before, but what used to be the number one cause of mortality in scleroderma was scleroderma renal crisis, which are the yellow bars here. And while that's been declining, percentage-wise, the largest factors for mortality in scleroderma are pulmonary hypertension and interstitial lung disease. And that's important because I think that's going to be one of the things when we talk about our routine visit. That's one of our goals a lot of times as docs. And so I think I'll be interested to hear from some of the folks living with scleroderma today. I think the perception when I talk to some of my patients that they get is that folks come in and have a lot of symptoms that we're trying to address, and that when we're trying to talk about their need to get a pulmonary or an echocardiogram or pulmonary function test, if somebody's not symptomatic, I think it's important for us to explain why we think it's necessary to get those tests, because otherwise sometimes it feels like we're not really addressing their primary reason for coming in, and we're really just trying to get our own agenda across the table. So what do we do in terms of a visit? So this is by no means exhaustive for what we do during a visit, but we're obviously, first of all, trying to address the patient's symptoms and concerns. So if that person is struggling with Raynaud or they're struggling with skin tightening, that's usually the first thing I talk about. I ask them how they've done since the last time I saw them. Then there's also stuff that I'm trying to gauge that maybe isn't a primary complaint of the person, but I want to make sure that they don't have life-threatening internal organ involvement. And so I will, if I'm not prompted by it, I'll ask about their frequency and the severity of the Raynaud's, because if I put them on an intervention, I want to know if it's actually better. I'll probe by history for GI symptoms, because in this regard, an exam is not usually that helpful. An abdominal exam, unless somebody has intestinal pseudo-obstruction or intestinal motility issues, is not going to give you many answers. And then I think it's important, this last one, we really want to ask about shortness of breath, because some folks with scleroderma, really their functional mobility is impaired to such a degree that they might not be stressing themselves as much in terms of exercise as much as they did before they were ill. And so they might say, like, I don't have any kind of shortness of breath, but then I think it's important to follow that up by what their activity levels are. In terms of exam, so again, this is kind of correlated from both my experience and then when I talk to other experts in the field. The recommendation is usually to check a skin score every 3 months in diffuse patients. So we're usually seeing folks that frequently, if not more frequently, early on, every 6 months in limited, and then after 4 to 5 years, we'll sometimes back off, not necessarily in visits, but maybe in formally recording the skin score. We're looking for things like tendon friction rubs, joint contractures. We'll measure oral aperture, and I'll go through that when we have some of the folks with scleroderma come up. We check blood pressure. So this is important. If someone has early diffuse disease, it's not just a blood pressure in clinic, but we usually encourage them to get a blood pressure cuff at home and to check it at least once weekly, usually twice weekly, because if they notice a rise in blood pressure at home, we want to know about that. We'll do a heart and lung exam. We'll do a joint assessment. Nail fold capilloroscopy. I didn't bring over the equipment for that today, but I'll show a slide on it soon. And then we'll assess for telangiectasias and for weight as well. And then studies, so this is controversial. Again, we don't have a good best practices paper about what to do, but I think most individuals would say that annual PFTs are important because it gives you information not only about interstitial lung disease, but it can also give you information about pulmonary hypertension. I have a slide on that as well. I put here consideration of annual echo. I don't do an echocardiogram every year, but just so that you're aware, the American College of Cardiology and some European guidelines say that is recommended to consider that every year. I'm not sure of the added utility if you're already getting pulmonary function tests every year, but it certainly could be considered, and there are guidelines out there that say that you wouldn't be at fault for doing that. We get a baseline CT scan to assess for chest involvement, but I don't follow that up with annual scans because of the radiation exposure. Certainly if someone has a change in symptoms, if their pulmonary function tests have changed and we can't explain that, then I will follow up with a CT scan, but I don't regularly scan somebody who has no new symptoms and has stable PFTs. And then a lot of these labs here are more important for people in early disease because we're trying to assess for kidney involvement, and that can be through blood work or through the urine assessment. A lot of patients with developing scleroderma renal crisis can have a fall in the platelets as one of their first signs, so that's why I included CBC. Others to consider that are probably even more controversial, so yeah, we know even less about, would be an EKG. Some people would say that that's important just to assess if there's any baseline cardiac defects. I say it's controversial because it's not known, unlike myocarditis that's more common in maybe systemic lupus, we don't know that it's actually an inflammatory process rather than fibrotic, and there's been no actually even good case reports of intervention with immune suppression that can help that aspect. So we certainly get it if we're going to use a pro-motility agent like domperidone, because that can be associated with cardiac problems, so we'll always get one at baseline. BNP and uric acid are up here because there are some algorithms out there about how to screen for pulmonary hypertension. And the DETECT paper, I think I have the reference on a future slide, was probably the best one that was done, and it's basically a step-by-step algorithm so that you can determine who needs to go to echo, and then based on those echo findings, who needs to go to a right heart catheterization. And one of the 6 parameters, or 2 of the 6 parameters that they had were BNP level and a uric acid. So sometimes we'll consider that if we're going to use the algorithm. All right, wanted to leave enough time for this, so we'll have at least 20 minutes to kind of do some exam stuff. So these are the things that we're going to try to focus on. We're going to talk a little bit about the skin score. That'll probably be actually the majority of the time during the exam portion of what I want to kind of talk to folks about. And then we're going to do a little bit on tendon friction rubs. I don't know if anyone, does anyone? Okay, you're testing yourself. That's good. None today. That's probably a good thing, right, Sandy? I don't want you to. Well, I'll go through a little bit about how we gauge oral aperture, digital ulcers. Joint assessment, I'm probably not going to focus a lot on that, but we will look just in case a different medication for joint inflammation. Thankfully, a lot of joint inflammation is a little bit less common in systemic sclerosis. Certainly joint pain can happen because of the flexion contractures and the skin involvement, but actual joint inflammation is a little bit more rare. And then again, if you're going to do that detect algorithm for pulmonary hypertension, presence of telangiectasias is actually one of the risk factors for pulmonary hypertension. So I think at least looking for that would be helpful. So I think without talking anymore, do we mind if we have everyone come up? So we have Ken coming up. So I've been told I can tell a little bit about, Ken is not a patient of mine, but he's a patient of Dr. Fisher's.
So I was diagnosed with limited on March 30th of last year, and then Dr. Fisher diagnosed me with diffuse on July 7th.
Okay. And then do you mind sharing a little bit, because you told me a little bit about your treatment history, maybe just with the group?
Yeah, I met Dr. Fisher for the first time on July 7th, and within 10 minutes of meeting me, he was extremely concerned and actually referred me to for a stem cell transplant, which I had done in December at Northwestern University Hospital. So unfortunately, we're not sure it worked. So I'm getting symptoms back, and it's coming back rapidly. And it's not uncommon for symptoms to come back after a transplant, and it kind of settles in and the transplant kicks in. But because mine are coming back so rapidly, we're moving forward as if it did not work. So, and hoping it did.
Good.
Well, so that's where I'm at.
Well, I think maybe what would work better, because we're kind of focusing on the camera too, is we'll kind of do maybe one person at a time, just so we don't have like so many people up. So here, I think we can set this down, and then maybe what we'll do, Ken, if you don't mind taking a seat over here, and if you guys want to get closer, I guess without blocking the camera, that's totally fine. So, because I don't know how much you'll be able to see. So seriously, I mean, if you guys want to kind of come up a little bit closer, because what I'm going to do, I don't know that I can project up on the screen or anything like that. Or you can sit in your seats, whatever. So, one of the first things I do when I will assess somebody with scleroderma is, one, try to assess some of the flexion contractures. So obviously, that's affected Ken's fingers, unfortunately. And so if anyone wants to come up, what you can feel here is you don't have necessarily a tendon friction rub, but you can kind of feel your tendon grating. So maybe Patrick, I'll pick on you if you want to come up.
My Achilles they creak.
Are also. So if you put your finger underneath there and you kind of extend out his finger, then you can find it almost feels like crepitus of the tendons. This is an important finding because in somebody with early diffuse involvement, what do we, for any of the fellows, what do we worry about with tendon friction rubs and risk? So, well, I mean, you can have definitely tendon compromise. The other thing would be scleroderma. It's been associated with scleroderma renal crisis as well, so with rapid skin involvement. So I think it's something that we want to assess as well. How is your range of motion in your wrist? Is it pretty? Yeah, so I think you actually do have a tendon friction rub in your wrist too. So I don't know if anyone else wants to come up. Okay, yeah. So if you put your kind of thumb across this area, you're kind of feeling it, and then and it almost kind of feels like a little vibration underneath there. So I think when there's that involvement. So if we're doing the modified Rodnan skin score, so it's important. I'll have you rest your arm just so you're not having to hold it up. We check for it in kind of defined areas. So it's between the MCP and the PIP. It's the dorsum of the hand, the back of the forearm, not the volar surface. So the dorsum of the back of the arm, upper arm. Chest, the chest usually just by kind of prior protocols is underneath the clavicles above the breast line or above the nipple line. So that's for chest involvement. Abdomen is around the umbilicus. And then you do thigh, anterior tibia, and then the dorsum of the feet. Neck is not included anymore. It used to be years ago, and then the face, and that's usually by just underneath the zygomatic arch. It's been protocolized so that there's uniform kind of data collection between studies. It's usually recommended that if you're able to, for any clinics that are working with multiple providers, it's best if it's done by the same examiner, because there's a lot of inter-reader variability, meaning if I do it one day and someone else does it the next, the score might not be exactly the same. The most important thing is the change over time. So ideally, you have the same person doing the score. And that doesn't mean the same person has to see, because if you need to get in quickly and there's someone else available. But in terms of purposes for making decisions on medication changes, it's usually best if it's the same person. So the score is basically out of 51, and it's rated from 1 mild, 2 moderate, 3 severe. And so if I'm going to look at Ken's fingers here, usually what I'll end up doing is we test all 4 sites. When we've went to study meetings before, there's 2 types of examiners, I've been told. One is a maximizer, meaning if one of the fingers is a 3, then some people will say that's a 3. And then other people are averagers. Again, that's probably why there is some variability, because there's no set nomenclature on how it has to be done. I tend to be an averager, but it's important to have the same person doing it over time. So when I'm examining Ken's fingers, I can get some mild wrinkling in some, but what I'm trying to do basically is I'm pushing in from the outside with 2 thumbs. And obviously with a lot of folks with no skin involvement, you can actually pinch skin up. With most folks with systemic sclerosis, you can't get that much of a pinch, but in some folks, you can at least see wrinkling of the epidermis with pressure from 2 sides. On Ken's 5th and 4th finger, I can't really get any kind of wrinkling. On your 3rd or 2nd and 3rd, I can get some. So again, if I was an averager, I'd probably say this is a 2, but it easily, some people could rate that as an involvement of a 3. On the back of the hands, just as an example, I'm not able to kind of get any kind of puckering up of the skin. So again, this would be a 3. So we would do that, and then we add up the scores. You can relax your arm. There's not a set threshold, like you have to be above this score to be a candidate for treatment. Most treatment trials are in folks with diffuse involvement. I've treated individuals with limited systemic sclerosis, especially if it's crossing a joint. So if it's crossing a wrist joint and threatening range of motion, even if they don't have proximal involvement, you could consider that. But again, the higher the score, the more we get concerned about the functional limitations that I'm sure you've had, and then the internal organ involvement as well. So I had you on the spotlight for a while. Was that okay? Mm-hmm. Okay, good. Maybe I'll ask someone else to come up with it. Thank you, Ken. Thanks so much. And we'll still want to kind of get more input from you in a little bit. All right. Who's this? Bobby Joe, do you want to come up? No, yeah. It's your friend that comes with you, right? Do you mind sharing a little bit about how long you've been diagnosed, and I'll give you the baton?
Okay. My name's Bobby, and of course, I was actually originally diagnosed in 1982 with lupus. And so that's been a while back. I did all sorts of treatments for that, mainly prednisone. Had a lot of anti-malarial drugs, Plaquenil, everything like that, and nothing really seemed to work. And in 2004 was when I was diagnosed with scleroderma, pulmonary hypertension, and pulmonary fibrosis.
Okay. And have you, in terms of treatments, if you don't mind sharing, have you been put on medicines for pulmonary hypertension?
Yeah, when I was first originally diagnosed, I did go on Flolan for 2 years. And then I was on one of the study groups for the tadalafil. And then eventually I was weaned off and started Interclear.
Okay. Well, along with your pulmonary hypertension, have you had problems with Raynaud's, or is that not as big of an issue?
Yeah, I do have problems with Raynaud's. Mine is more, I do have a little bit of skin, but mine is more internal.
Sure. Yep. Okay, good. I'll take this. And if you don't mind taking a seat. So thank you for sharing. I think that this brings up the point that some folks with systemic sclerosis don't have a lot of outward manifestations in terms of skin involvement. And so, in addition to the diffuse and the limited kind of subsets that we described before, there's a third subset, and if someone doesn't have any skin manifestations, then we'll say that's systemic sclerosis, sine, or without scleroderma, but they can still be at risk for obviously a lot of the internal organ involvement as well. Do you mind if I just look at a couple of things? So I might do less of a skin exam, here, in terms of when I will look for vascular changes, we obviously will look at the digital tips. So digital ulcers, if we were doing a trial to look for a medication to be effective, we measure them only usually at the ends of the digital tuft. And the reason for that is that a lot of micro trauma with daily use can cause sores in the back of the knuckles. And so because that contribution to sores, a more pure vascular marker is usually on the fingertip tuft. So one of the things I'll do at first is I'll actually have a person raise their hand up, because a lot of folks with vascular involvement will have one of two changes. They'll either have a kind of flattening of the end of the digital tuft, or they can actually get kind of a narrowing of the end of the finger. So that's really the definition of sclerodactyly, is a tapering of the end of the digit. And sometimes we can see that. And I think in yours, I can actually see that you've lost a little bit of this kind of the roundness at the end of the finger. And then, does it look? Have you had? This might be an old sore here. Have you had any active sores more recently?
More the calcinotic
changes. Okay, good. Where do you normally have the calcium changes?
Right here.
Right on the outside.
Right on the edges.
On those two.
And this.
And right here too.
That's
so
where they come. Yeah.
That's probably a good way or a good time for us to explain. So people have probably heard the term crest before, right? So we just had a resident that came in the other day. We tend not to use the term crest a ton. So crest stands for calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. It's not bad to use the term, but we try to get away from it because really that used to be used synonymously with limited systemic sclerosis, and patients with diffuse can have just as many of those manifestations. And then it confused patients to say, like, no, I don't have limited systemic sclerosis, I have crest, when really they were kind of almost the same thing. So we try not to use that. But calcinosis can happen, and it probably does happen more commonly in limited. Similar to like gout tophi, if they happen, it's usually over the extensor surface. So again, microtrauma is thought to be one reason for them to develop. Have you had problems with sores that didn't heal from those as well? Or
No, they've healed.
They've done okay? Okay. Sometimes that can be a problem too. So if I'm looking for calcium deposits, I'll usually look at the dorsum of the hands along the tendons, and then a lot of times, at the elbows as well. And so no history of any kind of, no one's ever told you about any kind of tendon friction rubs or anything like that, right? Okay, good. So we'll do skin assessment. We'll look for, I think I lost my microphone here. We'll look for digital alterations, flexion contractures, and then the last thing that we're going to do will be a cardiopulmonary exam as well. We'll talk a little bit about screening, for pulmonary hypertension, because to be honest, if somebody was developing lower extremity edema, or if they had signs of a loud P2, that would obviously be pretty advanced pulmonary hypertension. So we're hoping to catch it earlier than that. Any kind of problems with swallowing or anything like that? You do as well?
I have vocal cord paralysis.
As well. Do they think there's a contribution from the heartburn from that?
Supposedly because of the Sjogren's. So the Sjogren's has been added.
Causes problems too. Okay. Yeah, we've seen some folks because of, heartburn can obviously not only be a symptom problem. It's also something that, there's some studies that show that acid, when it comes up, it can hit the vocal cords and cause vocal cord irritation, hoarseness of a person's voice. And the other thing is that there's some studies that show that the progression of fibrosis is worse in people that have a dilated esophagus or a higher symptom score for GERD. So there's always a little bit of a controversy about how much acid reflux actually contributes to pulmonary fibrosis as well. Is there anything you'd like to share? I mean, it sounds like you went a long time in between the diagnosis of lupus and scleroderma. I mean, was it a different doctor, or did you develop new symptoms that someone said kind of, aha?
No, it was actually, I started developing different.
Oh, yeah.
I actually started developing different symptoms. Lupus was pretty much, I had lots of pain and bone and things like that. But when I started With the pulmonary issues, I would get dizzy quite a bit. Whenever I was, where there were mountains and things like that, then I would get short of breath, and I would have to stop quite a bit. But then eventually it got to where I started really passing out, and then that's when I ended up in the hospital quite a bit. The first diagnosis that they really made was the non-specific pneumonia, and then so from there, because I kept fainting quite a bit, they went ahead and started doing the testing and did a bronchoscopy and things like that.
I mean, the diagnosis. Yeah, I think that's it. You know, we've all seen patients, even if it's not with systemic sclerosis, we've seen patients with maybe incomplete lupus or other things that have taken a long time, and it's tough because you probably ran across some good doctors along the way, but especially without a lot of external skin involvement, that can be a hard thing.
Speaking of doctors, I'm originally from New Mexico, so I was seeing a rheumatologist, the better half of all my years there. But that was one frustration, was that he never really paid attention to what I was telling him. Yeah. So that really is frustrating, because he would always attribute everything to, it's your disease process. It's just part of what you're going through. But I started with quite a bit of, he would diagnose me with asthma, bronchitis, things like that, and a cough that I would just never get rid of. But he never really did anything as far as doing any more follow-up studies or anything, until I ended up in the emergency room. And
then are you still in New Mexico now, or are you here? You're here in Colorado? Okay, good. Well, thank you so much. Why don't you share a little bit about just your diagnosis and everything?
I've had symptoms of scleroderma for about 5 years. They first started when I was pregnant with my second child. They diagnosed me with undifferentiated connective tissue disease, which, because of my pregnancy, we had a lot of problems treating and testing for things. We're pretty sure I had lupus. And it wasn't until my daughter was 4 months old, Dr. Fisher actually did diagnose me as well. I am the classic uncontrolled Raynaud. I have the sores on my fingertips. I'm nervous, so it's even worse. I started with prednisone, went to Celcept or mycophenolate, did methotrexate, and also did Cytoxin. I don't know how to say the long
No,
word.
that's great. Yeah.
So I've done all of those, and now I am currently doing IVIG treatments. I took about 1.5 years off after the Cytoxin infusions because they're extremely difficult just to go through. And so took 1 year off and then just started IVIG. I just completed my 6th round of that. My major involvement is skin. I have skin involvement from my head to my toes. Some days I feel it's really major, but in comparison, it can be minor to some other skin involvement. I don't know what else to say.
How do you feel like, if you don't mind me asking, how do you feel like the IVIG has gone so far?
I think it's so hard for me to tell. And I'm not sure if I'm alone in this as a scleroderma patient, but is it disease process? Is it actual treatment that is working? The way my disease has progressed is I do well, and then I kind of flare up, and then I do well, and then I kind of flare up. When I flare up, that's when I go see Dr. Fisher, and he puts me on medication, and we argue about it. And so then, is my flare kind of slowing down just because of the disease process, or is it actually the treatment? Sure. So I'm continuing on IVIG. My itching has slowed down quite a bit. I'm not as swollen. I can tell as I get closer to my month, the end of my month, that I do have some more itching and swelling and pain. So, yes, it is working.
Good. All right. Well, yeah, if you don't mind taking a seat. So, again, if people want to get a little bit closer, because I think, again, it'd be helpful if people have never seen a digital ulcer or if they've never seen skin involvement in the past. So this would be an example. I think again, you guys won't be able to see it from far away, but there's a sore on the outside of the finger. And when I said we didn't count it before, that doesn't mean it's not important, and it is related to the low blood flow. But again, just if we were counting them up to try to track things over time, because you have how many kiddos?
2.
You have 2. Yeah, the amount of banging that moms probably have to go through with their hands each day, we don't want to take that into account. So if I turn your hands over, so she has some sores on at least 3 or really all 4 and 5 of the fingers on her side. So we would normally add them up, so each sore individually on the finger, and then I usually do track those over time to try to see if any of the interventions, are you on any blood pressure medications?
Still Denafil now.
Okay.
Yeah.
And so, it's helpful. We want to know not only are her Raynaud symptoms improve, but we'd like to see if the digital sores are going to improve as well. What's interesting is that not every patient, and I don't know if this has been your experience, but not every, at least the folks I see, not everybody does their Raynaud's, the improvement or the lack of improvement, does it correlate with their digital ulcers? And again, that probably has to do with the fact that Raynaud's really is the vasospasm portion, and the sores might be more of just that narrowed artery. So some folks might say, like, yeah, I'm not getting as many attacks of whiteness or numbness, but I'm still getting sores. And so I think as long as they're getting some benefit, I usually wouldn't stop the meds. Has that medicine helped you very much? Or
my sores haven't gone away in 5 years. So since right before I got diagnosed, I've had sores and
kind of continuously the entire
continuously. They were definitely worse in the beginning.
Yep.
And now they're just they stay like that
all the time.
Yeah.
Do you notice any kind of improvement with seasons or not really?
Yeah, absolutely.
Yeah.
But then it's actually spring and fall are the hardest, because you can prepare for summer for air conditioning, you can prepare for winter, but it's when you're outside and it's 70 and then all of a sudden there's a breeze.
Sure. And
it's 50. And then the Raynaud's really, really kicks in. So those are my hardest
the biggest
seasons.
Issues.
Yeah.
So I'm just going to feel down here. And you've never had, they've never felt the need to do any kind of blood vessel evaluation or anything like that?
Yet.
Yeah. Mm-mm. Okay, good. So sometimes I will, do Allen's test or something to assess for more proximal disease. It's rare. So there is a study out of South Carolina that in some folks, they're forming a lot more sores in their fingers, especially if it happened in the summertime, because like you said, it's more reliably better, but it's not. I've never met a person with scleroderma who said they're fine in the summer, but it's usually just a little bit better. If someone's worsening in a winter or a summer month, then some of the things that I'll think about is that, some folks with scleroderma can have antiphospholipid antibodies, and there's some experts who would recommend that if there's antiphospholipid antibodies, that might be someone that would actually benefit from anticoagulation. And then this study that from South Carolina showed that about 15% of people that had resistant digital ulcers, when they did angiograms, they had proximal radial occlusions that might be amenable to doing an angioplasty. Again, that's a small subset. Most people don't have that. And the other problem is that you need to make sure that you have someone who's skilled, because the risk in blowing up one of those arteries or dilating is that they could throw small clots off to the end of the fingers. You said the involvement kind of goes all the way from kind of feet all the way up. Mm-hmm. So it involves kind of chest as well as the upper arms. Yes. So one thing that we didn't show, so I think we talked a little bit, you can kind of see it's not classic for the salt and pepper changes, but you can kind of see she's lost some of the pigment. I don't know if people can kind of see that from back here. And again, in the resolution or in after the inflammatory phase, some of the pigment loss is fairly common. Although, again, if this was the only thing, I wouldn't be able to say it's classic, just that alone. But yeah. And then the last thing here, how long have you had the diagnosis again?
4 years.
It's been 4 years.
4 years, yeah.
You said the itching just got better recently?
No, it comes and goes. When I flare up, I itch.
So one thing that's interesting, and maybe after I'm done, since no one wants to come up during the talk, it seems like, so maybe you can ask. So on her forearms here too, you have kind of these raised bumps. Mm-hmm. Now, if you scratch, then it could just be related to that. But sometimes what we'll see with dermal edema, and it's usually more early on in the process, is that you can get some cobblestoning of the skin, and it can get some rough. And usually that's when, at least in my experience, when someone's like very intensely puretic, it's from that kind of active inflammatory phase. Did you use any low-dose prednisone at any point during the course?
Yeah, during my entire pregnancy.
Yeah.
And then probably for a good year after I was diagnosed, I was on the prednisone just because my itching and swelling was so intense.
What else, do you know what else Dr. Fisher or any other doc tried for the itchiness? Maybe you could share with anyone.
I've tried topical steroid creams. I went and saw a dermatologist. They gave me some lotions. What else? Xanax.
Sure. Yeah.
Because at night it was so intense at night that I was getting sores from scratching.
Yeah.
So, but nothing really it will help it a little bit, but until my skin really stops progressing and inflaming, then it's there.
It's there.
Yeah.
Okay. Well, I think I only want to keep everyone for about like maybe 5 more minutes. Maybe it'd be helpful, Ken and everyone, and Bobby Joe, maybe I'll have you guys kind of come up, and then this will be an opportunity for folks to maybe ask some questions if we get one more. Thank you.
And maybe they can pass that back.
Yes, and we'll actually use it. So we'll start off. All right. I'm going to flip through just because I don't think I have anything else here. Okay. So I thought we already talked a little bit about kind of like your guys' history, but I guess, so now that you guys all have experience of working with somebody in rheumatology with this diagnosis, I guess, what would you say that you're looking for, like in